Hi, good evening all. This is your Dr. Bharath Kumar VD, Pharma faculty. So in this YouTube session, we will have the PYQ or PYT related discussion for your upcoming FMG 2026 exam. So before I begin, just want to confirm the audio video is fine. Let me check from my side. Okay. So just message me if everything is fine. Sai Krishna, good evening. Just tell me whether the audio video is fine. Okay, so everything is set and we will start our discussion soon. Okay, audio is little low, just to confirm. Okay, so mic is closer to me. Good evening, Abbar, Jovit, Sai Krishna. Welcome. And we'll start with the first question. It will be an interactive MCQ based discussion. So try to answer. 42-year-old man is scheduled for surgical resection of adrenal mass after presenting with episodic headaches, diaphoresis, and severe palpitations. So what comes to your mind when you think of adrenal mass, headaches, diaphoresis, severe palpitation? So the common diagnosis what comes to our mind is pheochromocytoma. So what happens in pheochromocytoma? There is increase in adrenaline or in production, so the BP goes up. That's why the patient has headaches, diaphoresis, and palpitations. And also the lab parameters, they show elevated catecholamines and metanephrines. Now, to prevent hypertensive crisis during surgical manipulation of the tumor, which of the following medication should be initiated in the preoperative period? So before surgery, what we should give? Because we have to control the BP, otherwise BP will shoot up and patient may have problems during surgery. So before surgery, to decrease BP, what drug should I use? Yes, the answer is option A, phenoxybenzamide. Phenoxybenzamide belongs to non-selective irreversible alpha blocker. So remember, phenoxybenzamide is a, yes, Gabbar, it will be helpful. So phenoxybenzamide is a non-selective irreversible alpha blocker. Now can we give propranolol? Yes, you can give, but whenever you treat pheochromocytoma, you have to always use alpha blocker. Then after some days you have to give beta blockers. Never give beta blocker first in pheochromocytoma. If you give beta blocker first, the BP may shoot up. Now there is a drug called tamsulosin. Tamsulosin is a alpha 1A selective blocker. Alpha 1A selective blocker, which is given to manage a condition called BPH, benign prostatic hyperplasia. Now tamsulosin, similar to that, we have a drug called prazosin, which can also be used in BPH. But prazosin will also help in managing one more condition, and that is called hypertension. Prazosin will also help in managing hypertension. So somebody having BPH with hypertension, the drug preferred is prazosin. Now can you tell me in this discussion section, what is the drug of choice for scorpion sting? So put it in the comment section. What is the drug of choice for scorpion sting? Now we have another drug called phentolamine. It is also non-selective but reversible alpha blocker. And phentolamine is also used for pheochromocytoma. It is given IV for pheochromocytoma, but it is during surgery, that is intraoperative we give. And not only that, we use phentolamine to bring down BP in two conditions, that is cheese reaction and clonidine withdrawal reaction. Yes, Sai Krishna, you are right. The drug of choice for scorpion sting, which is a pediatric question, the answer is prazosin, which comes as a syrup, we can give it. So the answer for this first question is phenoxybenzamine, which is a repeatedly asked question. Now the next thing we need to understand is beta blockers. How do you understand beta blockers? All the beta blockers end with lol, atenolol, acebutolol. But which one is cardioselective beta blocker? A simple understanding is any beta blocker whose name starts from A to N, they all are cardioselective beta blockers. Any beta blocker name starts from N to Z, they are called non-selective beta blockers. Sir, what is this N? N is nebivolol, which is cardioselective. Nadolol is non-selective. Now tell me, if prazosin is there, if there is propranolol, whether it is cardioselective or non-selective? Yes sir, it is non-selective. So we understood cardioselective and non-selective beta blockers. Now we have certain beta blockers which are alpha plus beta blocker. The alpha plus beta blocker drugs are two drugs. Number one, carvedilol, labetalol. So we have two drugs. Number one, the name is carvedilol, and number two, the drug name is labetalol. Now the question is again, are these two drugs cardioselective? No, they are non-selective beta blockers. But why should I know this, sir? Please understand, these non-selective beta blockers are contraindicated in a patient with asthma. Bronchial asthma, you cannot give non-selective beta blockers. So can I give labetalol in a asthma patient? No. Carvedilol? No. Any drug from nadolol to Z drugs? No. Again they will ask you, which is the shortest acting beta blocker? Then your answer should be esmolol. The longest acting will be nadolol. The one which closes potassium channel, and the name is called sotalol. The name is called sotalol. Now, if you remember the antiarrhythmics, we have four classes. All the beta blockers belong to class 2, but sotalol belongs to class 3. The reason is it has potassium blocking property. And the last one you should answer, what is the antidote for beta blocker overdose? What is the name of the antidote? Anybody? Sai Krishna, Mishra? Yes, tell me the antidote name. Yes, very good. The antidote name is glucagon. The antidote name is glucagon. Very good. Let's take into the second question. The second question is, an elderly male presents with history of urine hesitancy, urine retention, ultrasound reports post-void urine is 130 ml. Which of the following drug is used to treat the condition? Now tell me, in an elderly person having urinary problem and post-void urine is more, the diagnosis is benign prostate hyperplasia. Nowadays in FMGE exam, they are not asking directly what is the drug of choice for BPH. For BPH, what we use is a drug called 5-alpha reductase inhibitor. And the name of the drug is finasteride. Finasteride is a drug which is a 5 alpha reductase inhibitor used for BPH. But will finasteride work immediately in BPH? No, it is slow acting. Now, what is the faster acting drug for BPH? The faster acting drugs are alpha blocker. Just now I told you the name is tamsulosin. They are faster acting, or prazosin. Then why are we giving finasteride in BPH? Is to decrease the size of prostate. So finasteride decrease the size of prostate. Do we use androgen blocker? Yes, we have an androgen blocker. The name is called flutamide. And flutamide is not used for BPH. It is used for a cancer in a male, and that is prostate cancer. Prostate cancer is a hormone dependent cancer which depends on testosterone, so we block testosterone. That is called androgen blocker. Then we have aldosterone antagonist. The name is called spironolactone. Spironolactone, what is the main adverse effect? Anybody can mention here? It's an aldosterone antagonist, but it has one common adverse effect which is tested. It is the gynecomastia. It causes gynecomastia, loss of libido. But for BPH, here the treatment is 5 alpha reductase inhibitor. Okay, clear? Yes, sir. Yes, Jovit, very good. Now let us move to the next question. 48-year-old patient is having abdominal colic, abdominal pain due to acute gastroenteritis. Which of the following drug is used mainly to relieve the colicky pain? So we have physostigmine, glycopyrrolate, dicyclamine, neostigmine. Tell me the answer. Yes. Yes. The answer is dicyclamine, or you can use another drug by the name hyoscine. So these two drugs are very commonly given in colicky pain. Now tell me, can we use morphine in a colicky pain called biliary colic? So I want yes or no from you people, whether we give morphine in abdominal pain due to biliary colic. Yes or no? Yes or no? If you tell no, then you are right, because morphine worsens the pain by contracting sphincter of Oddi. So don't give morphine in biliary colic, don't give morphine in head injury, and don't give morphine in a patient with bronchial asthma. So these three conditions, morphine should not be given. Okay, contraindicated. Okay, sir. Whenever you think of physostigmine, this drug crosses blood-brain barrier, and it is a drug of choice for which poisoning? Yes. Anybody? Which poison we use this physostigmine? Yes, very good, Jovit. If you give morphine in head injury, it increases the intracranial pressure, correct. Glycopyrrolate is given as pre-anesthetic medication. What is the advantage? It decreases the secretions. Then what is the advantage if it decreases secretion? It decreases the chance of aspiration pneumonia, and also decreases reflex vagal bradycardia. So we give it before surgery. So physostigmine is a drug of choice which poisoning? Yes, not that. Come on guys. Drug of choice for atropine poisoning. Atropine, also called as datura, also called as belladonna poisoning. Coming to neostigmine, is brother, one more neostigmine का brother क्या है? It is pyridostigmine. These two drugs They don't enter the brain, blood-brain barrier. Then where do you use these drugs? These drugs are used in a problem of neuromuscular junction. What are the problems? Number one, they are given in cobra bite. Why we give in cobra bite? To reverse, to improve the muscle weakness. Second, they are used in a condition called myasthenia gravis to treat. MG means myasthenia gravis. Third, they are used to reverse skeletal muscle relaxants like curium or curoniums. Three conditions they are used: cobra bite, myasthenia gravis, and reverse skeletal muscle relaxant. In all these conditions, they improve the muscle weakness. Now tell me, what is the drug used to diagnose myasthenia gravis? Yes, what is the drug used to diagnose myasthenia gravis? The name of the drug is edrophonium. And the test what we do is called tensilon test. So this is what we covered in this question. Now I want to add some more here. What are the drugs used for a condition called Alzheimer's disease? Alzheimer's, remember the mnemonic. The problem is memory. So the mnemonic is guard the memory. So G stands for galantamine and R for rivastigmine and D for donepezil. Remember, donepezil starts with D, so that is also the drug of choice for Alzheimer's disease. And what is decreased in Alzheimer's disease? The neurotransmitter is acetylcholine. And memory, the drug name is memantine. So these are the drugs for Alzheimer's disease. Now what is available as a patch is rivastigmine is available as a patch. Very good, Sai Krishna. Let's move to the next question. Which of the following statement is false? Adrenaline is the drug of choice for anaphylactic shock. True, 100%. Whenever there is anaphylactic shock, we use adrenaline in the dilution of 1 in 1000, and it is given by intramuscular, and the dose is 0.3 to 0.5 milligram. And the muzzle what we prefer is vastus lateralis, VL. So it is true statement. Norepinephrine increases systolic, diastolic, mean artery pressure followed by a reflex bradycardia. That is also true. Now why it causes reflex bradycardia? When the mean artery pressure is gone up, the BP is high, there will be stimulation of baroreceptors. So these baroreceptors will tell the brain to stimulate parasympathetic and reduce the heart rate. And that is called reflex bradycardia. Dopamine is used in cardiogenic shock with oliguria at infusion rate of 2 to 10 microgram per kg per minute. Yes, true statement. Now dopamine we use it in various dilutions. Dopamine 1 to 2 it acts on D1, 2 to 10 it acts on beta 1, more than 10 if you give it acts on alpha 1. So that is dopamine for you. Then obviously when you know all the three are true, then which will be the false? Dobutamine mainly acts on dopamine receptor and used in hypertension emergency. It's a false statement. Dobutamine never works on dopamine receptor. Dobutamine mainly acts on beta 1 and it's not used in hypertension emergency. It is used in cardiac stress testing, and also it's used for cardiogenic shock, cardiac stress test. Right? So this is the wrong statement. So what should I know in here? Adrenaline you should know. Norepinephrine also called as noradrenaline, and dopamine, what doses, what does it do, you should know. Okay, yes. But many a time they will ask you the drug of choice for shocks. For all the shock with hypotension, which drug will increase the BP? The drug is noradrenaline. For any shock with low blood pressure, the drug of choice is noradrenaline. Septic shock, we give antibiotic. Neurogenic shock with low BP, noradrenaline. Hypovolemic shock, we give fluids, and if there is low BP, noradrenaline. Hypertensive shock also we give it. But the question is, will noradrenaline work on anaphylactic shock? You have to tell me whether noradrenaline works or not. What is the drug of choice for anaphylactic shock? It is adrenaline. Epinephrine, also called as adrenaline. NEET, yes, we'll make one more session, don't worry. Adrenaline is a drug of choice. Now tell me, what is the antagonism between adrenaline and histamine called? The main culprit for anaphylaxis is histamine. What is the antagonism called? Anybody? The antagonism is called physiological antagonism. Will we use noradrenaline for anaphylactic shock? No, because noradrenaline is not a physiological antagonist and noradrenaline has no beta 2 action. Because of that, we don't give it in anaphylactic shock. It won't work. So this is the summary what you have to remember in these emergency drugs. Okay. Let's move on to the next question. Why I took case based? Because nowadays the questions are case based. Just try to analyze. 35-year-old woman presents to the neurology clinic seeking treatment for blepharospasm that has significantly interfered with her daily activities. After discussing treatment options, the physician decided to administer local injection of botulinum toxin. What is the mechanism of action of botulinum? So, can you tell me the answer, guys? Yes. What is the answer? The answer is the mechanism of action of this botulinum toxin is it causes degradation of snare protein and prevent the presynaptic release of acetylcholine. Now, most of you might have heard of snare protein in physiology. Even though you don't know snare protein, at least you should have known it prevents the release of acetylcholine. So if I take the neuromuscular junction, let me tell you, clarify this. How the drugs work in neuromuscular junction. This is the nerve. This is the muscle, skeletal muscle. Now this is the synapse where our acetylcholine is stored. So whenever the action potential comes, it is released. This one gets fused. So it acts on the receptor called NM and NM. Then you see skeletal muscle contraction. So this botulinum will not allow the release of acetylcholine. Now if acetylcholine is not released from presynaptic, the muscle will relax. Now what is a drug which competitively block acetylcholine? The names are, they are called non-depolarizing skeletal muscle relaxants. What is the name of that? The names are D-tubocurarine, or their names end with curium, or their names end with curonium. So these drugs, they competitively block acetylcholine. Now my question to you all, very beautiful question. Suppose I have given D-tuberculin to a person. How do I reverse it? What drug is used to reverse D-tuberculin action? I will be very happy if you answer this. Now the drug which stimulates the neuromuscular junction is a skeletal muscle relaxant called succinylcholine will also do that. Now we have a receptor in skeletal muscle which releases calcium which is required for contraction, the receptor name is called ryanodin receptor 1, RYR1. Tell me which drug inhibits RYR1. The name of the drug, beautiful name, it is called dantrolene sodium. It is called dantrolene sodium. The dantrolene sodium, it's a drug of choice for, dantrolene is a drug of choice for anybody? Yes, it is the drug of choice for neurolept malignant syndrome. Second, it is also used in malignant hyperthermia. Both the condition, the muscle rigidity is seen. So the drug of choice is dantrolene. Yes, Journey, very good. Jovit, very good. Now, I was asking you a question, how do you reverse D-tuberculin? I just discussed that point. Either we give pyridostigmine or we give neostigmine to reverse them. But if somebody had commented, there is a reversal agent called sugammadex. Now tell me, where do you use this to reverse? We use this to reverse mainly two drugs. Remember Ravi. To reverse rocuronium and vicuronium, we use a fast-acting drug and the name is called sugammadex. So we can use that also to reverse. Only two drugs have been approved for reversal, rocuronium and vicuronium. Now tell me one more thing, which skeletal muscle relaxants undergo Hoffman's elimination? Yes, very good, Jovita. Which skeletal muscle relaxant undergo Hoffman's elimination? FMG question, already asked. The name is atracurium. Atracurium has a sister, it is called cis-atracurium. What is the advantage of this? These drugs, they don't depend on liver or kidney for elimination. So these are safe in patients with renal failure or liver failure. So very, very important. Yes, Jovita, Journey, very good. So the answer for this question is option C. Botulinum toxin decrease the release of acetylcholine from presynaptic terminal. Okay, yes. Yes, let's move on to the next question. Let me keep the mobile here. Okay, the question reads like this. 58-year-old male patient, a BMI of 31, so obviously obese. His physician started him on a drug for managing obesity. Patient also has moderate obstructive sleep apnea. Which of the following drug is used for diabetes also, and it's a GLP-1 and GIP agonist? Anybody? Try to answer this. Yes, come on. Now, it's a new drug by the name tirzepatide. It's a GLP as well as GIP agonist, and it is also used in diabetes type 2. We can also use liraglutide and semaglutide. Liraglutide and semaglutide, they are GLP-1 agonist. Let me take this. Liraglutide and semaglutide are only GLP-1 agonist, which is used for diabetes also, obesity also. Orlistat inhibits an enzyme called lipase in the intestine. So what happens if you inhibit lipase in the intestine? The adverse effect of orlistat will be loss of fat in the stool, and what we call it as steatorrhea. Not diarrhea, it is steatorrhea, passing fat in the stool. Please understand, all these 4 drugs are used to manage obesity, and obesity is a trending topic. They will ask you this. Okay, yes. Let's move to the next question. 29-year-old woman is brought to emergency department in respiratory distress and is diagnosed with acute severe asthma. So she has acute severe asthma. The emergency team initiates aggressive management. In the pharmacology of asthma medications, which of the following agents does not possess bronchodilator property? In short form, which of the following is not a bronchodilator is the question. Yes? Can you answer? Ipratropium bromide and tiotropium bromide are bronchodilators. So we call them as SAMA and LAMA. Theophylline inhibits the enzyme phosphodiesterase and they belong to methyl xanthines. They are also bronchodilators. Formoterol, salmeterol. These are called LABA, long-acting beta-2 agonists. These are also bronchodilators. Then we have salbutamol and terbutaline. Terbutaline. They belong to SABA. They are also bronchodilators. Which is not a bronchodilator is option D, sodium chromoglycate. What is this, sir? It is a mast cell stabilizer. And it is not used for attack of asthma, it is used for prophylaxis of asthma. Now can you tell me the drug used for prophylaxis, which is a IgE blocker? Yes, tell me the name of the drug. Tell me a drug which is a leukotriene receptor antagonist for prophylaxis of asthma. Yes, let me tell the name. The name is called Montelukast. How to remember? It has leukotriene name in the drug name. What is the name which is IgE blocker? Yes, Jovita, you're right. The IgE blocker name is omalizumab. Yes, very good. Most of you are telling that correct. Mohammed Sai Krishna, very good. So please understand, IgE blocker, Montelukast, sodium chromoglycate, all are for prophylaxis of asthma and they are not bronchodilators. Can anybody tell me a drug used in asthma which is a LOX inhibitor? LOX inhibitor, the name is xyluton. You read the name, leukotriene luton. Now tell me something like this. A drug which inhibits the enzyme COX. What is the group name a drug which is inhibiting COX called? Yes. Yes, very good, RK. That is xyluton. But what is the drug name which blocks COX? The name is NSAIDs, non-steroidal anti-inflammatory drugs. They inhibit the enzyme COX. Okay, let me move on to the next question. A frequently asked question in FMGE. Let us read this. 30-year-old flies directly from Delhi to Leh Ladakh. So he went from Delhi to Leh Ladakh directly. Within 24 hours of arrival, he develops throbbing headache, nausea, dizziness, fatigue and difficulty air sleeping. Pulse is 100, okay. Respiratory rate a bit high, 22. And saturation is 88% on room air, that is a bit lower. No signs of pulmonary edema. What is the best immediate management? Immediately आप क्या करेंगे? Immediately आप क्या करेंगे? I know you are prefixed with some of the answers. Now what I want you to analyze is, what is this case? Patient went from Delhi to Leh Ladakh, which is at high altitude. So he is having high altitude sickness. So वहाँ क्या होगा? ऑक्सीजन का कमी होता है. High altitude sickness is also called as acute mountain sickness. So this is seen when you go to high altitude where the oxygen levels are low. So read the question carefully. They are asking immediately आप क्या करेंगे? Now you imagine this situation, you are with your friend developed this. Immediately आप उसको नीचे लेके आएंगे या पहले जो अवेलेबल है वो देंगे? मैं तो क्या करूँगा, जो अवेलेबल है, वट एवर इज अवेलेबल इमीडिएटली एट दैट प्लेस, ले लद्दाख, तो मैं पहला दवाई दे देता हूँ इमीडिएटली. If it doesn't become all right with that, then I will go for immediate descent. Immediate descent ऐसा नहीं होता है कि वो you just take him to the top of the mountain and throw him down. The helicopter should come, pick him up, and then he has to go down, which takes time. Now tell me, even the question is same. That's why it is called PYQ and PYT. How they can twist the question. So I will prefer acetazolamide and I will give oxygen immediately. क्या करेंगे, सैचुरेशन लो है ना, क्या करेंगे आप लोग, ऑक्सीजन दे दो, acetazolamide दे दो. अगर कम नहीं हुआ, then bring him down. You all agree with this? If you agree, put a thumbs up. Now when he comes down, I can give dexamethasone. तभी दे सकते हैं. Now I don't want this problem, sir. I want to go to Leh Ladakh. So then you take prophylaxis. What is the drug of choice for prophylaxis of acute mountain sickness? And that is also acetazolamide. Okay. If they ask you what is the best management, then go for immediate descent. But हमें immediately क्या करेंगे, अब दे दो दवाई. That's why the language differs. So this is a frequently asked question. Then they asked, what is the mechanism of acetazolamide? It's a carbonic anhydrase inhibitor and it acts on PCT and causes bicarbonate loss. So the drug of choice for acute mountain sickness, both for prophylaxis and treatment, is acetazolamide. Okay. Now, whenever I talk about diuretics, you have to understand the diuretic of choice for certain conditions. Acute mountain sickness or high altitude sickness, just now I told you, it is acetazolamide. Pulmonary edema or left ventricular failure, that means we use a loop diuretics and the name is called furosemide. Furosemide is also diuretic of choice for nephrotic syndrome. But whenever I discuss, these are loop diuretics. But where they work in loop of Henle. Which part? Thick ascending loop of Henle. And what do they inhibit? They inhibit sodium, potassium, 2-chloride cotransporter. Then cerebral edema, the drug of choice is mannitol. Mannitol is also drug of choice for acute congestive glaucoma. Cirrhotic edema. What happens in cirrhosis? The aldosterone levels go up. Aldosterone causes sodium and water retention and edema. So you have to give aldosterone antagonist. The name is called spironolactone. Spironolactone is also given in resistant hypertension. And we know it is a aldosterone antagonist. Spironolactone is also given in hirsutism. Why, sir? It blocks androgen receptor, so it can prevent hair growth. Spironolactone. Acute congestive glaucoma, I told you the drug of choice is mannitol. Tell me the last one, lithium-induced diabetes insipidus. What is the diuretic of choice or drug of choice? Anybody? The name is amyloride. Am I the Lord? What does it inhibit? It inhibits ENaC. What is ENaC? epithelial sodium channels where at the collecting duct of nephron. So these are the diuretic of choices for various conditions. Okay, yes. Now, what are the drug of choice are neurogenic, meaning brain problem, central. Diabetes insipidus, the drug of choice is desmopressin. It's a vasopressin 2 receptor agonist. Nephrogenic, problem is in the kidney, then the drug of choice is thiazides. Now whenever I talk about thiazides, what is the site of action of thiazide is early part of DCT. But what do they inhibit? They inhibit sodium chloride symport. They inhibit sodium chloride symport. Lithium, I told you. SIADH, what is the drug of choice? The names are Vaptans. Let me tell you the name. Tolvaptan. What is the mechanism of tolvaptan? It's a V2 receptor antagonist. SIADH, syndrome of inappropriate antidiuretic hormone. Right? Yes. Let's move on to the next question. 52-year-old male presents with headache, confusion, visual disturbances, nausea, vomiting, seizures. Blood pressure is 220/110. Which of the following is the most appropriate to this patient? What do you think? 220/110, visual problem, seizures. So I will tell the patient is having hypertension emergency. There is end organ damage. So what drug will you prefer? Oral drugs will not work immediately. Sublingual nifedipine is not used nowadays because it was causing reflex tachycardia. So we have two choices, labetalol and IV nitroglycerin. The drug of choice for hypertension emergency is IV labetalol, option C. I don't know why most of you are taking nifedipine sublingual, that is, the practice is not there. So we'll go for IV labetalol. Okay, then control the seizures. So go for option C, labetalol. Agar labetalol nahi hai, then you can give IV another drug. The name is called nicardipine. CCB, calcium channel blockers can be given. Now tell me, suppose a pregnant woman has hypertension, then what is the drug of choice? The drug of choice is labetalol. Suppose the pregnant woman has hypertension and asthma, then tell me what drug will you give? Come on. Yes, Journey, it is also given subarachnoid hemorrhage. Subarachnoid hemorrhage, it is nimodipine. Labetalol cannot be given in this case 2. This is case 2, this is case 1. Reason is labetalol is non-selective beta blocker. So the problem is you can't give it. In this patient, I can give either nifedipine sustained release, or I can give the safer one, methyl dopa. So these are the safer ones. Okay, so it is the safer one. Now let us move on to the next one. What are the first line drugs for hypertension? Whenever we think of hypertension, what are the first line drugs? I told you the mnemonic ACT. A for ACE inhibitors, PRILs, ARBs like sartan, then C for CCBs, and T for thiazide. These are first line drugs. Now even after using these three drugs, if the BP is not coming down, then we go for spironolactone, which is the drug of choice for resistant hypertension. Now sometimes patient may not come like this. Patient may have hypertension with BPH. Then tell me, what will be the antihypertensive of choice for this? Second, patient may come with hypertension, anxiety, patient has migraine. Then what antihypertensive will you prefer? Tell me 1 and 2. Third also I will give, patient has hypertension plus gout. Tell me what will you avoid in the third case? Which antihypertensive will you avoid? So we got 3 cases. Case 1, I will give prazosin. The reason is simple. Prazosin can manage both. Journey to heal, tamsulosin will not work on hypertension. So I will prefer prazosin. Hypertension, anxiety, migraine, I can use a beta blocker. So beta blockers will take care. But the third question is hypertension with gout. Which drug you should not use? I should not use thiazides. Why, sir? They increase uric acid. Already gout, there is more uric acid. So don't give it. Hypertension with gout, thiazides are not given. But what can I do? Hypertension with gout, which one should I prefer, sir? Hypertension with gout, the preferred one is losartan. The reason is losartan lowers the uric acid. Remember the name, low, it lowers uric acid. Losartan can be preferred. Okay, yes. Since we are discussing hypertension, which hypertensive drugs, or simply in a pregnant woman, which hypertensive drugs are contraindicated, not given? They are pril, that is ACE inhibitor, sartan, they are ARBs. The reason why they are contraindicated is these drugs are teratogenic. What do they do, sir? They cause renal agenesis in the fetus. So pregnant, don't give pril and sartans. Okay, yes. Yes, Sai Krishna, you are right. Yes, try to answer this question. Sometimes nowadays pharmacokinetic questions are coming, so that's why we have included that. Loading dose of a drug depends mainly on, remember loading dose, LD, remember VD, it depends on volume of distribution. Clearance, the maintenance dose depends on clearance. So some of the pharmacokinetics formulas they can ask you, because recently there was a question, T half means plasma half-life is given by 0.693 into volume of distribution divided by clearance. So these formulas will be useful. Loading dose is equal to how much you require target plasma concentration into volume of distribution. If they have given viability, you write it divided by F. F means viability. Now usually viability is written like this. It can be written as 0 to 100%. Suppose you want to write it in the letter F, it is written as 0 to 1. Meaning, suppose they gave in the exam 60% viability, then the F will be 0.6. That is the meaning. Maintenance dose is similar. It is target plasma concentration into clearance. Maintenance dose means you have to give repeatedly. So into dosing interval, how many times in a day you give is dosing interval divided by viability of the drug F, if they have given. Viability is 100, right? Yes, 100 only. If you give IV, if you give oral, then the viability is less. That is why loading dose depends on VD, maintenance dose depends on clearance. Now certain pharmacokinetic formulas not so important for you, so let us move on, but these are important. Which route has 100% viability? The only route which has 100% viability is IV route. Rate of drug absorption is given by, rate is always by the time, Tmax. Extent of drug absorption, how much is absorbed, is given by area under curve. What routes have first pass metabolism? Only two routes. Oral and rectal routes have first pass metabolism. My question is, does sublingual route has first pass? Yes or no? Comment. Sublingual has no first pass. Not only this, no other route, or they have very less first pass, but these two routes have very significant first pass metabolism. Weekly basic drugs, where do they bind? They bind to alpha 1 acid glycoprotein. Weekly acidic drug bind to albumin. And which drugs undergo Hoffman's elimination? I told you the names are atracurium. If it has sister, cis atracurium. Now the last one you should tell me, drug for rare disease or rare condition is called. Anybody? What is the drug for rare disease or rare condition called? The drug is orphan drug. Example of an orphan drug is digibind. What is digibind, sir? It's an antidote for digoxin toxicity. Yes, Jovit, you're right. Krishna, right. Now, ED50, effect dose 50 is a measure of potency. LD50 divided by ED50 is called therapeutic index. So therapeutic index is a measure of drug safety. Meaning, if therapeutic index is wide, drug is more safe. If therapeutic index is low or narrow, it is less safe. What do you mean by TD50? TD stands for toxic dose 50. Means it is the dose causing toxicity in 50% of patients. But similarly, if they ask you LD50, it is called lethal dose 50, which was asked in FMGE. Lethal dose 50 means the dose required to kill 50% of animals. So both are same only, but TD50 we use it for humans, LD50 we use it for animals because we kill animals in experiments. That's why. Okay. Let me give you a graph. The graph is dose response curve, DRC, dose curve. This is the efficacy, this is the potency. Let me draw the drug. A, B, C, D. Just a minute. C, D. Now tell me, Among A, B, C, D, which was is more potent? Tell me the drug which is more potent. Yes, you got the help, Jovid James. Very good. So whenever you check for efficacy, check the height. Help. Height efficacies. First, let us tell the efficacy. A and B are equally efficacious. Same height. Then comes D. Then comes C. Potency. Check the left side. Who is more left side? D. Then A. Then B. Then C. So the more potent drug is D. I think most of you have practiced it plenty of times and these questions have arrived. Very good. Good job. Let's move on to the next question. 56-year-old patient has essential hypertension on AC inhibitor for 6 months. He develops chronic refractory dry cough. What would be the correct action to be taken? So patient is on pills. Now he is having cough. What do? Reduce the dose, give antitussive, change to ARB, or get a CT scan to check for tuberculosis. What will you do? Come on. So the best option is to change to ARB. Now what we need to understand in this MCQ is what are the adverse effect of pills or AC inhibitors. Number one, they cause dry cough. And number two, angioedema. Angioedema means swelling of the lips, swelling inside the glottis, everywhere. Now these dry cough and angioedema is due to the AC inhibitors. When they are used, they don't allow the degradation of bradykinin and substance P. So bradykinin levels go up, substance P goes up. So these are responsible for causing dry cough and angioedema. So this is not done by ARB, so they don't cause it. What are the other adverse effects of them? They can increase potassium. These are teratogenic, avoid in pregnant women. They can decrease the blood pressure. So these are the major adverse effects you have to remember. So when a person develops dry cough with AC inhibitor, don't give cough syrup, don't reduce the dose, just change to ARB. That can be done. Okay. Let's move on to the next question. 45-year-old man with a history of chronic alcoholism has been abstinent from last 3 months. He is not drinking, he is on de-addiction therapy. He consumed 60 ml of alcohol at a social gathering. So he went to some party, there they forced him, drink 60 ml, nothing, kuch nahi ho jayega. Within 15 to 20 minutes, he developed flushing, headache, nausea, vomiting, hypertension, breathlessness. Which drug he is taking for alcohol dependence? Anybody? Disulfiram, acamprosate, naltrexone, topiramate. Yes, obviously, he is on disulfiram. Disulfiram is also called by another name, and abuse. This drug inhibits an enzyme called aldehyde dehydrogenase. So what happens if you inhibit this enzyme? The acetaldehyde level goes up and that is going to cause disulfiram like reaction. Now acamprosate, naltrexone, topiramate, these are also used for de-addiction. They decrease craving of alcohol. Particularly the tested drug is always naltrexone. Remember the mnemonic NOTA. Naltrexone, ondansetron, topiramate, acamprosate. So these are drugs for alcohol de-addiction. But tell me, Which anti-amoebic drug can lead to disulfiram-like reaction? Yes, you know the name. The name is metronidazole. Suppose a person is already on metronidazole and drinks alcohol, he will develop the same issue. Not only that, there is a cephalosporin called cefoperazone. Even this can lead to disulfiram-like reaction. So since we are discussing the alcohol part, de-addiction, let me also discuss some other de-addiction program. Nicotine smoking. One of the drugs for smoking cessation is varenicline. We have another drug called bupropion. Bupropion belongs to NDRI, and we have nicotine replacement therapy. But the most effective drug for smoking cessation is varenicline. Again, they will ask you the de-addiction program of opioid. So de-addiction, we use replacement of opioid, and they are either I can give methadone or I use a drug called buprenorphine. These are for de-addiction program. Sometimes these addicts, they may develop relapse of addiction, and that time, to prevent relapse, we use a drug called naltrexone. We use a drug called naltrexone. Okay, so we covered 3 de-addiction program: opioid, smoking, and alcohol. A patient presents with chronic stable heart failure with ejection fraction of 35%. So this is called heart failure with reduced ejection fraction. Heart failure with reduced ejection fraction. Which of the following drugs will not reduce mortality? Death will not be reduced. Or which of the drug will not increase longevity? सेम मीनिंग वाली, अगर वो नहीं मर रहा है तो जी रहा है. ACE inhibitor will prolong the longevity. Spironolactone will do, gliflozins will do, but digoxin is not going to do that. So what are the drugs used in heart failure which increase longevity or decrease mortality? The mnemonic I have told you plenty of time. It is sub. Yes for spironolactone and SGLT2 inhibitors. A for ACE inhibitor, ARB, R9, and B for beta blocker. So only these 3 drugs reduce mortality or increase longevity in CHF patients. Digoxin will not reduce mortality, it will only increase the force of contraction. Since I am discussing digoxin, can anybody tell me what is the mechanism of digoxin? It inhibits sodium potassium ATPase in myocardium. Digoxin toxicity can cause ventricular tachycardia. Then what is the drug of choice? You can tell me. Yes, Sai Krishna, you are right. What is the antidote for digoxin overdose? The answer is for VT due to this thing, it is lignocaine. Lignocaine is also called by another name lidocaine. Antidote name is digibind. It is also called as digifab. So these are the things. Digoxin, please understand, digoxin increase the force of contraction, but digoxin will not decrease mortality. So nowadays, where is the use of digoxin? Suppose somebody is having heart failure and somebody is having atrial fibrillation, both, then we use digoxin. Yes, most of you know it, very good. Yeah. A big question, but easy. 45-year-old male present with severe burning epigastric pain that is temporarily relieved by food intake. So what is ulcer? Food intake reduces the pain, that is duodenal ulcer. The physician prescribes a medication that does not alter pH but polymerizes in an acidic environment, pH less than 4, to form a sticky gel-like paste, binds to ulcer base and creates a barrier. Which of the following drug was prescribed? So what is a drug which is a ulcer protective? Yes, most if you answered it, the name is sucralfate. Remember, sucralfate changes the fate of ulcer. Now again the question is, can I give sucralfate and antacids together? You comment yes or no. Pyrazipine is also used for peptic ulcer disease, but it is an anticholinergic drug. Drugs ending with prozole are proton pump inhibitors. What do they inhibit? They inhibit H plus, K plus, ATPase. And they inhibit this enzyme irreversibly. Now, these PPIs are drug of choice for conditions like peptic ulcer disease, Zollinger-Ellison syndrome. What is Zollinger-Ellison syndrome? You have high gastrin levels. And also they are the drug of choice for GERD, gastroesophageal reflux disorder. Misoprostol is also used. It is a prostaglandin E1 analog given for peptic ulcer disease. But sometimes NSAID can induce peptic ulcer disease. The drug of choice for NSAID induced peptic ulcer disease is PPI. So please understand, for all these conditions, the drug of choice are PPIs, proton pump inhibitors. Okay, I think we are in already 1 hour into the class. So before I proceed further, so tell me whether this class is useful, the speed is fine, your understanding, are you getting the revision? Just tell me. How is the classes going on? Okay. Now, whenever I talk about gastric problem, so always they ask you the question, H. pylori eradication. H. pylori eradication, we use PPI with some antibiotics. The mnemonic for antibiotic is ABC trademark limited. Okay. So the problem is, what are the antibiotics? A for amoxicillin, B for bismuth, C for clarithromycin, T for tetracycline, metronidazole, and L for levofloxacin. Do we use all these? No, we use 3 drugs regimen. For example, we use a PPI plus amoxicillin plus clarithromycin, or we use PPI plus clarithromycin plus metronidazole. Now, how many days we give this regimen? It's 14 days. So even that has been tested in your FMG exam. So this is how we manage H. pylori eradication. Okay. Okay. 32-year-old male presents with recurrent episodes of sudden onset of palpitations, dizziness, and mild chest discomfort. He also has history of asthma. ECG during one such episode confirms PSVT. Which one of the following is used for prophylaxis of PSVT in this patient? Yes. What is your answer? Waiting for your answers. Now the point is, yeah, I will increase my speed, but you also should increase the patience level, because read the question carefully. Read the question carefully. Yeah. See, patient is having PSVT. Suppose it's an emergency, the drug of choice will be IV adenosine. But the question is, patient is requiring prophylaxis. Prophylaxis I cannot give adenosine. So PSVT, prophylaxis, I can give two drugs. Either I can give beta blocker or I can give CCB. So we have two options. Propranolol cannot be given here because it's an IV drug. So what I can give is oral verapamil. So read the question carefully. I know you know the answers, but you know the examiner can trick you. Okay. He knows where you make mistakes, so don't make the mistake. Now suppose instead of IV propranolol, they would have given oral propranolol. Will you choose this answer? No, because patient is also having asthma. And patient is having asthma, I don't want to give non-selective beta blocker. So the safest option will be verapamil. If you got this concept, if you understood the value of patience in your exam, please put a thumbs up here. That's why these sessions are called PYQ or PYT. So the examiner is not going to bring some new questions. Even though they bring, it's new for everyone, don't worry. But whatever is already been asked, are you thorough with that? That's the major question we get. Okay, sir. Now again, please understand these points. Whenever they give arrhythmia, a case of arrhythmia, you have to always analyze in the question whether the patient is stable or patient is unstable. If the patient is stable, then we use drugs, antiarrhythmic drugs. BP is fine, everything is fine. But if the patient is unstable, the BP is low, shock we give. And then we go for drugs. So read the question carefully and then answer the treatment. Similarly, what is the drug of choice for VT? The drug of choice for ventricular is amiodarone, or you can use the drug lignocaine. Suppose patient is having V fibrillation or patient is having pulseless VT. Tell me, what will you do next? That will be the question of medicine and pharma. VFib or pulseless VT, what is your next step? Answer me. See, if there is VFib, ventricular fibrillation, and pulseless VT, no pulse means patient is unstable. So that's why we give shock, DC shock. Then not responding, then we go for drugs. So this is how the question keeps on changing. unless you understand the concept thoroughly. Okay, they can't bring the questions out of this world. Now tell me, what is the drug of choice for torsades de pontis, also called as long QT syndrome? The name is magnesium sulfate. Magnesium sulfate. Okay. The next one. 45-year-old female patient undergoing her first cycle of highly emetogenic cisplatin-based chemotherapy experiences acute onset, severe vomiting within 4 hours of starting the infusion of cisplatin. Which is considered the primary drug of choice in this case? Please answer. Now this is a case of early CINV, chemotherapy induced nausea and vomiting. Early means if that occurs within 24 hours. So if you see the question, it is within 4 hours, so the best drugs are cetron. Cetron are 5-HT3 antagonist. There is one more problem called late CINV, which occurs between 1 to 5 days of starting chemotherapy. For that, the best drugs are pitants, apripitant, natopitant, rolapitant, whatever. So they are neurokinin 1 antagonist. Sometimes we also have steroid. So these three combination, cetron, pitant, dexamethasone, these are the best combination for CINV case. CINV case. Nabilone belongs to cannabinoid 1 receptor agonist, and it is used for resistant vomiting, and also it has been used for anorexia in HIV patients. Cannabinoid 1 receptor agonist. Now let me ask you a certain question here. What is the drug of choice for morning sickness in pregnant women? Motion sickness. Tell me which antiemetic can cause torticollis or dystonia. The drug of choice for morning sickness is very good. Doxylamine with B6. Motion sickness is hyoscine. If not in the option, you can go for promethazine. And torticollis, what is the antiemetic responsible? The name is metoclopramide. How do you manage this torticollis? You have to give anticholinergic. The anticholinergic what we use is benzhexol. Benzhexol is also called as trihexyphenidyl. If that is not there, you can use benztropine, or another commonly available drug in the hospital are promethazine. You can give promethazine. So these are the things what they will ask you repeatedly in your FMG exams. Okay. So the answer for this question is option A, granny cetron. Cetron's drug of choice for early CINV. Let's move on to the next question. A 55-year-old male patient with history of MI comes to clinic with acute attack of migraine, which of the following drugs should not be given to this patient? Yes. Sumatriptan, ibuprofen, lasmiditan, ondansetron, which you should not give. See, myocardial infarction means he had ischemic heart disease. Ischemic heart disease means there is less blood flow. If already there is less blood flow, don't give vasoconstrictors. Vasoconstrictors are contraindicated. What are the drugs which cause vasoconstrictors? Remember the mnemonic case. Cocaine should not be given if somebody already had the MI. Amphetamine, nobody will give, but they may abuse. S for sumatriptan and E for ergots. These drugs should not be given if they have myocardial infarction. So in acute attack of migraine, triptan are the drug of choice, but here we cannot give because patient is having heart disease. What is the mechanism of sumatriptan? They are 5-HT 1B 1D agonist, and these will lead to vasoconstriction. So we don't give sumatriptan. So the answer is A. Can I give ibuprofen? Yes, relatively you can give. Can you give ondansetron? Yes, you can give. Can you give lasmiditan? Yes, it's a 5-HT 1F agonist given for migraine attack. It doesn't cause vasoconstriction. Then how does it work in migraine? It decreases CGRP levels. Suppose somebody have attack of migraine and heart disease, what is the preferred one if they ask you? The name is lasmiditan. The name is lasmiditan. Now, we know the drug of choice for acute attack of migraine is sumatriptan, but here due to heart disease, we prefer giving lasmiditan. Now, can you tell me how do you manage cluster headache? Yes, you would have heard of this plenty of times in the revision. What is the management of cluster headache? Tell me. Can you tell me a drug which is a 5-HT1A partial agonist used for anxiety? Yes, let me tell you that name. The name is called buspirone. So buspirone is a drug used for chronic anxiety. Don't confuse with bupropion. Yes, for cluster headache, the treatment is oxygen. If that is not there, you can still give triptans. Triptans can be given. Now suppose a pregnant woman, she goes for postpartum hemorrhage and she has ischemic heart disease also. Tell me, which one will you avoid? I will give three options: oxytocin, carbapenem, ergometrin. Which one will you avoid in this to prevent bleeding? Patient is having ischemic heart disease. Which uterotonic drug you will avoid? Same thing I will ask you. Pregnant woman, she is having asthma. Which one will you avoid in managing PPH? Come on. Ischemic heart disease, I don't want to give a vasoconstrictor, so I don't give ergots like methyl ergometrin and ergometrin. I don't give. PPH, pregnant women asthma, I avoid giving carboprost. Carboprost is a PGF2 alpha which can cause bronchoconstriction and worsen the asthma. These are all PYQs. These are not a new question framed by me. If it is already asked in NEET PG, FMG somewhere. Inducer inhibitor, I will tell you later journey. Okay. Let's go for another favorite for exam. A patient had pain and redness in grade 2. Uric acid levels are high. So whenever you think of high uric acid, one thing comes to your mind, gout. The doctor gave analgesic for pain and gave a drug for prophylaxis. The drug acts by inhibiting uric acid synthesis. The drug may inhibit following enzyme. So what is the drug name? The drug name which is given for prophylaxis or chronic gout, and the name of the drug is allopurinol. I call it as allopuri. So it's a xanthine oxidase inhibitor. It inhibits xanthine oxidase. One more drug which inhibits that is febuxostat. See, gout is a small topic, but mark my words, every year the exam questions come from gout. Now uric acid oxidase we don't have, but we have the enzyme called pegloticase, which is also given in chronic gout. For chronic gout we have another drug, and the names are called uricosuric drugs. They are called uricosuric drugs. And what are the names of them? Probenecid, sulfenpyrazone, and one more is called lesinurad. Lesinurad. Let me go up. Lesinurad. So there are three drugs for chronic gout: xanthine oxidase inhibitor, enzyme is pegloticase, and uricosuric drug like probenecid, sulfenpyrazone, lesinurad. All are for chronic gout. Then what is for acute gout? Let us come to the picture of acute gout. For acute gout, the drug of choice are NSAID. For chronic gout, the drug of choice are allopurinol. Number 1. Number 2, the drug used for acute gout is colchicine. So it inhibits microtubule polymerization. Not only that, it inhibits neutrophil chemotaxis. And the third drug we use are steroids. Acute gout. Now my question is, which NSAID is contraindicated in acute gout? Tell me, which antihypertensive is contraindicated in gout patient? So you have two responsibility to answer. Which NSAID is not given, which antihypertensive is not given. So the NSAID which is not given is aspirin. The reason is aspirin increases uric acid, so never give it. The antihypertensive which is not given in gout patient is thiazides. I told you already, they can increase uric acid. Thiazides are not given. So never miss gout for any exams. Small topic, only few concepts, 1 mark, easy. Okay. A patient on some psychiatric medication developed sudden rise in BP after consuming wine. Which of the following can be safely used in this patient among the following drugs? Yes. I think the question is skewed. So the question shouldn't have been like this. Which of the following drug is responsible? So patient after consuming wine, psychiatric medication, rise in BP. So this is called cheese reaction. So which drug is responsible for cheese reaction should have been the question. Now the drug which can cause cheese reaction are MAO inhibitors. So if you use MAO inhibitors, the tyramine enters the brain and releases norelin, so BP shoots up. And that rise in BP is called cheese reaction. And the drug which we use to decrease BP is phentolamine. Phentolamine. So let me tell you something about TCA. TCA poisoning, the antidote is sodium bicarbonate. You can use sodium bicarbonate. So the answer is option A, cheese reaction. Let's move to the next one. A patient of schizophrenia was on olanzapine therapy. What is olanzapine? It's an atypical antipsychotic. A few months. It was effective in controlling the psychotic symptom, but patient stopped taking the drug. What may be the most likely reason? Meaning, what was the problem with olanzapine, so he stopped taking the drug? Olanzapine or any atypical drug, the main problem is they can cause metabolic syndrome, which consists of weight gain. Because of weight gain, the patient would have stopped taking the drug. Now, which drug can cause achronocytosis among antipsychotic? The name is called clozapine. When you give clozapine, you should watch out for WBC count. Clozapine can also cause seizures at high dose. It can also cause myocarditis, and also it can cause wet pillow syndrome. But one advantage of clozapine is this clozapine has anti-suicidal effect. Can you tell me one more drug having anti-suicidal effect? Can you tell me that? Now, which atypical antipsychotic has least metabolic adverse effect if they ask you? The name is aripiprazole and ziprasidone. These have least weight gain problem. So most of the psychiatrists nowadays write aripiprazole. Aripiprazole being an atypical also has partial D2 agonistic property. And don't confuse aripiprazole with pantoprazole. This is piprazole. Now I told you which drugs have anti-suicidal property. One is clozapine. One more you should tell. Come on. Never miss that main drug. Lithium. Lithium also has anti-suicidal property, which is good for the patient. Then what drugs will cause tardive dyskinesia and muscular dystonia? Let us see that. Now this is a problem we see with mainly typical antipsychotics and less with atypical. And this problem we call it as extrapyramidal symptom. So the first problem that happens when you give typical is the acute dystonia. Suddenly the neck will turn to one side. So the drug for that is benzaxole, also called as trihexyphenidyl, or you can use a drug called promethazine. You can use it. Suppose you have a typical antipsychotic for elderly, they develop Parkinson-like symptom, drug-induced Parkinson disease. The treatment is same, benzaxole, promethazine. The third problem they may develop is akathisia, means inability to sit at one place. So the treatment for that is propranolol. or you can use benztropine, and the last resort will be benzodiazepines. The fourth problem is neurolept malignant syndrome. So this is a favorite for FMG exams. Neurolept malignant syndrome, the muscles are contracting, the temperature is going up. So the drug of choice is dantrolene sodium. Can anybody comment what is the mechanism of dantrolene? And which ion is responsible for neurolept malignant syndrome is the excess flow of calcium. Number 5, patient may develop tardive dyskinesia. So for that the treatments are benazine drugs. Valbenazine, tetrabenazine, these are used. The last problem is the perioral tremors or rapid oral tremors. This has also been tested, and there is no effective treatment for perioral tremors or rapid oral tremor. The mechanism of dantrolene, I told you, it inhibits a receptor called ryanodine receptor 1, RYR1. So you check any exam, you will see this extrapyramidal symptoms by typical antipsychotics repeatedly. So tell me one typical antipsychotic. Yes, the name is haloperidol, or the drug called chlorpromazine. They can cause this. So atypical, they will also cause, but lesser. So never miss this table. Okay. Yes. Next, move on to the next question. Which of the following condition and drug of choice are incorrectly matched? So read and tell me which one is wrong. Okay, so the answer for this question, the answer which is wrong is option B, myoclonic seizure phenytoin we don't give. Right, others are correct. So GTCS we give valproate, childhood absence we give ethosuximide, eclampsia we give magnesium sulfate. Let us understand the drug of choice for all these GTCS, juvenile absence. The drug of choice is valproate. If not there, we can give a drug by the name lamotrigine. Childhood absence seizure, just now we discussed, the name is ethosuximide. Focal or partial seizure, we use carbamazepine or lamotrigine. Pain while chewing in facial nerve distribution is trigeminal neuralgia. The drug of choice is carbamazepine. febrile seizures, we use midazolam, and we give midazolam in the nose, intranasal, or we use diazepam, and that is rectal. So midazolam is given into the nose, intranasal, or diazepam, which is given rectal. Infantile spasm or hips arrhythmia, it is ACTH. Infantile spasm with tuberous sclerosis, it is vigabatrin. Just a minute. And eclampsia, it is MgSO4. And for status epilepticus, what is the drug of choice for status epilepticus? The drug of choice is lorazepam. So this will be tested in your exams. Okay, yeah. Now the next question is, which of the following is not an adverse effect of lithium? Can you guess? It is teratogenic abstinence anomaly, correct? Fine tremors, hypothyroidism. It is not going to cause SIADH. What does it cause? It causes diabetes insipidus. It causes diabetes insipidus, not SIADH. And what are the other problems with lithium? Normal dose, it causes fine tremors. If lithium dose is high or lithium levels are high, you can see coarse tremors in the patient. Not only that, patient will have tinnitus, patient will have seizures. Then how do you manage lithium toxicity? We do therapeutic drug monitoring. So it should be between 0.5 to 1.5 milliequivalent per liter. If there is more than 1.5 milliequivalent per liter, it is toxicity, and if the patient has symptom, we manage the toxicity by doing dialysis. So more than 1.5 is toxicity. Now, will it cause teratogenicity? Yes, obviously. Fine tremors? Yes. Hypothyroidism? Yes. And toxicity can lead to this. Lithium is the drug of choice for bipolar disease prophylaxis. Lithium is also given for mania, but it will not work immediately. So for acute mania, we use antipsychotics. Let me write here. For acute mania, we use antipsychotic plus lithium. So this both are given to manage acute mania. But by bipolar disorder prophylaxis, you can give lithium. So lithium is again a favorite from psychiatric point of view. Yes, sir. Let's move on. A 45-year-old male has severe post-operative pain, is administered morphine 5 mg IV. You are monitoring him for opioid toxicity. On the basis of which of the following findings would you diagnose opioid overdose? Again a PYQ, repeatedly asked question. Okay. So the question is asking opioid overdose. Remember how to remember opioid overdose. The mnemonic is CPR, and hypo. So patient with opioid poisoning will be in coma. The pupil will be pinpoint pupil, that is myotic pupil, and patient will be having respiratory depression. There are three hypos you see in opioid poisoning. The three hypos are hypothermia, temperature is low, hyporeflux, and BP is low, hypotension. So these are typically seen in opioid poisoning. So tachycardia is not seen. Bradypnea, respiratory depression will lead to bradypnea. You will also see constriction of pupil and dilation of pupil. So on what basis, which of the following will make the diagnosis? I will have two answers here, B and C, both will be the answer, not dilation of pupil. But if we have to choose the better one, I will go for bradypnea. Constriction of pupil, if it is pinpoint, obviously I will go for that, but both are given, I will go with bradypnea. Respiratory depression means already the dose is very high, if both are given. Now the question is, when there is opioid overdose, what is the antidote? Usually they used to ask antidote in the exams, but nowadays they ask the features, clinical features. The antidote for that is naloxone. Why naloxone? Because naloxone is an IV drug, intravenous drug, so I can give it immediately and it will reverse that immediately. So the antidote is naloxone. Now please understand, in all the exams, the antidote is a must and know topic. Must know topic. So let us read the antidotes or revise again. For OP and carbamet poisoning, the antidote name is atropine. Atropine, belladonna, datura, the antidote name is physostigmine. Yes, Sai Krishna, naltrexone is oral. What we give is naloxone. Digoxin, I told you plenty of times. Cyanide, we use hydroxycobalamin. Benzodiazepine, Z drug and beta carbolin, we use a drug flumazenil. For cobra bite, we use anti-snake venom. But why do you use neostigmine, predostigmine? They improve muscle weakness. Digoxin, let me write again, digibine. Okay, yeah. Metoprolol is a beta blocker, so we use glucagon. Sometimes when you give valproate, the ammonia level go up, so the antidote will be carnitine. Ethylene glycol and methanol, huge tragedy. The antidote name is fomepizole. Don't confuse fomepizole with flumazenil. Remember, fomepizole has 2O and alcohol has 2O. So if the question comes, you should tell OO. Then opioids, I told you, calcium channel blocker toxicity. It is calcium gluconate. Let me write for opioid also, naloxone. TCA overdose also I told you, it is sodium bicarbonate. And the last one is for you to answer. For lignocaine, kya denge aap? And also you tell me, for magnesium toxicity, what is the antidote? Lignocaine overdose, we use 20% intralipid. Magnesium toxicity, the antidote is calcium gluconate. Yes, right. I want to ask you some more. Acute iron poisoning, What is the antidote? Yes, come on. It is deferoxamine. Suppose there is chronic iron overload. Then we use the same drug defer, but it ends with Cirox, or same defer reprone. So most of you will confuse this. Suppose the drug starts with defer and ends with amine, it's for emergency. Defer means remove the iron. But if it starts with defer and doesn't end with amine, it's for chronic. That's it. Remember like that. You won't have confusions. Yes, let me take another question. 45-year-old male diabetes patient was on anti-diabetic drugs. He forgot to take meals, went to gym. He started experiencing sweating, palpitation and tremors. When blood glucose was measured, it was 60, low, hypoglycemia. Which of the following anti-diabetic drug was used as monotherapy can cause hypoglycemia? So patient is experiencing hypoglycemia. So which drug can cause hypoglycemia? Sitagliptin, metformin, glimepiride, pioglitazone. So the answer for your question is glimepiride. Glimepiride belongs to sulfonylureas. So sulfonylureas, then meglitinides, and then insulin preparations. These are the only 3 group of drugs in diabetes which cause hypoglycemia when they are used alone. Then what about other drugs? Are all other drugs, they are anti-hyperglycemic, they reduce the glucose to normal. But these 3 drugs reduce the glucose below normal, that's why patients suffer with hypoglycemia. Patients suffer with hypoglycemia. That's the main issue. The patients suffer with hypoglycemia. Now, any drug ending with gliptin, remember these are DPP4 inhibitors. Now, if you inhibit DPP4, what will increase? It will increase the levels of GLP and GIP. And tell me, which gliptin is safe in renal failure? Tell me, which gliptin is safe in renal failure? Or you don't reduce any dose in renal failure, which gliptin? Come on. Metformin is a drug which is also called as insulin sensitizer. Because of that, it is also considered a drug of choice for diabetes type 2. Since it's a insulin sensitizer, the drug is also used for PCOD, polycystic ovarian disease. And nobody answered which gliptin is safe in renal failure. The name is linagliptin. Renal failure, you have to take lina. Lina lena hi hai. Whenever we give metformin to patients, they experience some of the adverse effect. Number 1, GIT upset, it is diarrhea. Patients will complain unexplained diarrhea. If you give that for a long time, there will be vitamin B12 deficiency, and very rarely the patients suffer with lactic acidosis. Pioglitazone, it's also an insulin sensitizer. But one important problem is it causes sodium and water retention, and then it has shown to increase the risk of a cancer called bladder cancer. Bladder cancer, these are all tested. So we understood the names. Now again the question is, the trending drugs called SGLT2 inhibitors. These SGLT2 inhibitors end with the name gliflozins, and their main site of action is proximal convertibule of nephron. These gliflozins nowadays are helpful in so many disorders, that is CHF, they decrease mortality. They are used in cardiovascular disease, they are used in chronic kidney disease, and they are also used, they are the main drugs nowadays for diabetes. So they have benefit in all these four gliflozins. But the tested exam questions are adverse effect. They cause loss of glucose in the urine, so glucosuria or glycosuria. Because of the bacteria grow, patient will have UTI, and also they may develop genital mycotic infections, that is fungal infection. So these are the tested aspect about SGLT2 inhibitors. SGLT2 inhibitors. Never miss gliflozins for exams. Suppose a person has diabetes and CHF, which diabetic drug will you prefer if they ask you? Obviously, we prefer SGLT2 inhibitors. They will help in heart failure also. Okay? Yes. I think we lost the power just a minute. Okay, let us take one more question and then I will take a break for a short period. 28-year-old woman at 8 weeks of gestation present with symptoms of palpitations, heat intolerance and weight loss. Laboratory evaluation reveals elevated free T4 and suppressed TSH. Diagnosis, you only know, hyperthyroidism, which is the most appropriate treatment in this patient. Remember, she is pregnant, hyperthyroid. What should be given? Come on. So remember the choice of drug in pregnant women first trimester. Remember the mnemonic पहले trimester में use होता है is propylthyrosol. Suppose she is on second and third trimester, then I can give either carbimazole or methimazole. Now these methimazole, carbimazole are also drug of choice for Graves' disease. And radioactive iodine should never be given in pregnant women because they are radioactive, they can cause the problem in the growing fetus. So the answer for this question is first trimester is propylthiouracil. Now why don't we give methimazole, carbimazole in the first trimester? What is the problem? The baby may develop scalp defect or goiter. So that is called cutis aplasia congenita. So the answer for that question is option A, propylthiouracil. Okay guys, so let us take a break, 10 minutes. And we'll sharply start by 8:10. Okay, until then relax and then we'll resume back. Thank you. Okay, let's resume. I think the audio video is fine. Let's move on. So the next question is 24-year-old pregnant female presented to the clinic with fever, frequency and urgency of urine. She is diagnosed with UTI. Which of the following medication should she avoid? So the question is directly asking you, pregnant female में कौन सा antibiotic नहीं देना है. So we use nitrofurantoin, we use penicillin which is safe, cephalosporins are safe, amikacin is not given because it belongs to aminoglycosides. Aminoglycosides are ototoxic, so they can cause toxicity to the fetus. So what are the safest in pregnant women are penicillins, P, cephalosporins, and M for macrolides. Macrolides like azithromycin, erythromycin, like that. So because of this question, we will be asking you, guess the teratogenic drug. Now tell me, which drug can cause phocomelia or sea limb deformity? Yes, the drug name is thalidomide. What drug can cause goiter, Epstein's anomaly and hypotonia? The clue for that is Epstein's anomaly, lithium. Mental and growth retardation both are given. Small phase micrognathia. Can anybody guess this? Renal agenesis is by ACE inhibitor or ARB. Any mental and growth retardation both are given. Always go for alcohol. So fetal alcohol syndrome, you see mental and growth retardation both. Neural tube defect, mainly an anti-epileptic drug called valproate can do that. Cleft lip, heart defects, small fingers, microcephaly, the drug is phenytoin. Now tell me which anti-epileptics are safe in pregnant women. Remember LL. Lamotrigine, levetiracetam are safe in pregnant women. Suppose there is a depressed nose, skeletal abnormality. The drug is warfarin. Cutis aplasia, skull defect, just now I told you, the carbimazole or methimazole drugs. Yes. Premature closure of ductus arteriosus. This will use if you use indomethacin or NSAIDs. They can cause premature closure of patent ductus arteriosus. Right. Now antimicrobials which can cause teratogenicity, cartilage damage is done by fluoroquinolones like ciprofloxacin, moxifloxacin, the floxacin drugs. Teeth discoloration and bone damage is by tetracycline. Then ototoxicity or nephrotoxicity is by aminoglycosides. Right. So they can ask you drugs to be avoided in pregnant women. So major drugs we have discussed. Let us move on to the next question. A 30-year-old male patient came with fever, headache, nuchal rigidity. Lumbar puncture shows gram-negative diplococci, that is meningococci. Which of the following is used for chemoprophylaxis in close contacts of this patient? So remember, diplococci gram-negative means meningococci, and you can see headache and nuchal rigidity, meningococcal meningitis. What is the drug for prophylaxis? The prophylactic drug is rifampicin, or you can use ciprofloxacin, or you can use ceftriaxone. So this is a repeatedly asked question. Prophylaxis of meningococcal meningitis. It is by rifampicin or ciprofloxacin or ceftriaxone. Now can anybody comment here? What do you give for typhoid carriers? What is the drug of choice for typhoid carriers? Let me tell you the drug of choice for typhoid. It is ceftriaxone. But for carriers, what is the drug of choice? The drug of choice is ciprofloxacin. Ciprofloxacin. Okay, let's move on. A 62-year-old male complains of severe burning pain over right half of his back from 2 days. The examination showed lesions as in the image. The affected region is tended to touch and red. Which of the following drug should be prescribed? See this? You can see the rashes, the fluid-filled vesicles. So this will point towards herpes zoster. So for herpes zoster 1, herpes zoster 2, varicella zoster virus, the drug of choice is acyclovir. And the drug of choice for that is acyclovir for this condition. Ganciclovir is the drug of choice for cytomegalovirus. Oseltamivir is the drug of choice for influenza A and B. And tenofovir is the drug of choice for hepatitis B virus. So the virus and drug of choice will be frequently tested in your exams. Correct. Let's move to the next question. A 35-year-old female is on treatment for TB. She complains of decrease in vision and color blindness. Which drug may be responsible? Remember, the drug is ethambutol. Remember, it starts with E. So ethambutol causes eye problems. Isoniazid has short form INH. So N, it causes neuropathy, and we call it as peripheral neuropathy, and the treatment for that is vitamin B6. H, the drug causes hepatotoxicity. Rifampicin starts with the R. So remember, it inhibits RNA polymerase. RNA polymerase, that is a mechanism. And the adverse effect also starts with R. It causes red color. So which red is it? It is called orange red discoloration of secretions. Not only secretions, urine will also become orange red. Pyrazinamide starts with P. So P means it causes pain. Which pain? Joint pain. Why joint pain? Because it increases uric acid. So these are the major adverse effect of the first line drugs for tuberculosis. Isoniazid, they can ask you the mechanism of action. It inhibits mycolic acid synthesis, which is a part of cell wall. Sai Krishna, pregnant women with hepatitis B, you have to go for tenofovir only. Lamivudine has low efficacy. Go with tenofovir. So isoniazid inhibits mycolic acid synthesis. Then the most important drug is nowadays is bedaquiline. Bedaquiline inhibits ATP synthesis in the bacteria, and the main adverse effect of the drug is QT prolongation, and the drug is hepatotoxic, liver toxic. And recently they had asked a question, what is the mechanism of bedaquiline? It inhibits ATP synthesis. So mainly they will test you isoniazid mechanism and rifampicin mechanism and first line drugs adverse effect mainly. Right. So once I am discussing rifampicin, I just want to highlight the point about enzyme inducers. Now here rifampicin is an enzyme inducer. What do you mean by that? If I give rifampicin increase the number of enzymes synthesis. So the metabolism becomes faster, the drug level decreases and drug will fail. So if you give rifampicin with OCPs will not work. So this will lead to contraceptive failure. So this is a frequently asked question for you. Second, enzyme inducer. Suppose a patient is having HIV and TB both. So the application they will ask you is, which one will you treat first, HIV or TB? First treat TB and then HIV. Second question they will ask you is, suppose a person is already on dolutegravir and he is also on rifampicin for TB. Rifampicin is an enzyme inducer, so it can affect the levels of dolutegravir. Then what will you do? What we will do is, we will increase the dose of dolutegravir. Increase the dose of dolutegravir. Sai Krishna, there are plenty of drugs which can cause QT prolongation. For your information, let me tell you, some antihistamines which are tested in the exams are estimazole and terfenadine. Some of the drugs used for GERD, cisapride, which can cause QT prolongation. Antibiotics, mainly the macrolides like azithromycin and fluoroquinolones, can cause QT prolongation. Just now I told you TB drug bedaquiline, then the drugs called delamanid, pritomanid, they can cause QT prolongation. Even antiarrhythmic drugs, that is class 1A and class 3 drugs, they are also going to cause QT prolongation. Okay, so these are major drugs which are tested in drugs. Now again, an antipsychotic drug which can be tested for QT prolongation is ziprasidone. There are plenty of drugs which can cause QT prolongation, but what I told you is frequently tested in exams. That is what I told you. So these are the application point of rifampicin, which can be tested as an enzyme inducer in your exams. I hope, Sai Krishna, you got the message. Okay. Okay, if you Google it, you will get 100 of drugs causing QT prolongation, but not 100 is tested. These things are tested. Yeah. Again, a favorite for FMG examiner is malaria. A 32-year-old man returned from a malaria endemic area with high-grade fever for 5 days. Examination is drowsy, confused and altered sensorium. Peripheral smear shows Plasmodium falciparum. What is the most appropriate treatment? Yes, can you comment on this? So it is Plasmodium falciparum. Now it is not a simple malaria, it's a cerebral or complicated malaria. Why, sir? Fever is high and you see the patient is drowsy, confused and altered sensorium. So it's an emergency. So the drug of choice is intravenous artesunate. Suppose a pregnant woman develops complicated malaria or cerebral malaria, still the drug of choice remains intravenous artesunate. Okay, single drug will be enough. Then we can give the oral drug. Okay, but let me expand the treatment which has been asked in exams for treating Vivax. So let me write like this. How do you manage Vivax? Vivax, chloroquine is given for 3 days. Plus we add primaquine PQ for 14 days. 14 days given for radical cure. If we are managing falciparum, so this falciparum is resistant to chloroquine, so we use a regimen called ACT regimen, artemisinin combination therapy. It depends on which part of country you are treating, northeastern part or rest of India. If it is northeast, the regimen what we use is artemether plus lumefantrine. Remember like this, me for northeast. For rest of India, the combination what we use is artesunate plus sulfadoxine pyrimethamine combination. For falciparum, there is no need of radical cure, so we use only one dose of primaquine in case of falciparum. Suppose it happened in pregnant women, then what to do? For Vivax, we only give chloroquine. That's it. No primaquine. Suppose you see falciparum in pregnant women, then for first trimester, what we give is main drug is quinine. You may or may not give clindamycin. Second and third trimester, it's okay. Then you can give artemisinin combination therapy depending on the area. That is how we manage in pregnancy. Because everything has been tested in your exams. The last thing they will ask you in malaria is prophylaxis of malaria. So somebody is traveling for malaria endemic area, and if they are traveling for less than 6 weeks, then the prophylaxis is given with doxycycline. So it is started 1 to 2 days before journey. This is the start of the journey. This is the end of the journey. So we are giving the doxycycline daily. And should we give after the patient coming from endemic? Yes, you have to give for another 28 days. Suppose a person is planning for more than 6 weeks of travel to endemic area. Then we use a longer acting drug, mefloquine, which works for almost a week. So we give it, this is the start of journey, end of journey. We give it 1 week prior. Then we give it every week. And after returning, we give it for another 4 weeks. So this is the prophylaxis of malaria. So never miss the treatment of malaria in and around. They are very, very particularly, you see all the PYQs. Without malaria treatment, there is no question paper. So whenever the things are repeated, you should not leave that question and go. New question, if you don't answer, that's fine. New question is new for all. But old question, repeated one, if you make mistake, then that's the biggest mistake. When you know the question, when you know the answer, then why make a mistake? Okay. Again, coming to the drug of choice for cryptococcal meningitis, the drug of choice is option B, liposomal amphotericin B plus flucytosine. Plus, you may give or may not give, but most important drug for that is liposomal amphotericin B. Again, the drug of choice for fungus is frequently tested. So let me tell you what are tested frequently. Mucormycosis, the drug of choice is liposomal amphotericin B. Liposomal amphotericin B is also a drug of choice for most of you know, Kala Azar, also called as visceral leishmaniasis. Cryptococcal meningitis also we use LAMB. What is LAMB? Liposomal amphotericin B. But you may or may not add flucytosine. Once the patient is stable, then we can shift the patient to fluconazole. So this is what we do in cryptococcal meningitis. So mucormycosis, you all know, cryptococcal meningitis, these are tested. Pneumocystitis xerosi, anybody? What is the drug of choice? For all this, chromoblastomycosis, chromomycosis, paracoccidioidomycosis, sporotrichosis, histoplasmosis, the drug of choice is itraconazole. So nobody is answering for pneumocystitis xerosi. It is Codri, moxazole. Very good, Jovita James. And then for all CCs, cryptococcosis, candidiasis, coccidioidomycosis, it is fluconazole. And for invasive aspergillosis, it is Oriconazole. And sometimes patient have allergic bronchopulmonary aspergillosis. So for allergy we use steroids, but to prevent fungus we have to give itraconazole. So deep mycotic infections are commonly tested in FMG exams on any exam. So please read this. Again, a major disease, HIV. HIV positive pregnant female delivered a baby. She is not taking any antiviral therapy. Which of the following should be started to the newborn? Yeah. So answer this. It's a PYQ. Okay, so come to this answer. Let me tell you the post-export prophylaxis to prevent mother-to-child transmission. So let me take two cases here to explain you in detail. Case 1 and case 2. So here also we have pregnant woman. This is also HIV positive. Here the patient is not taking any drug. No drug. Patient is on drugs for HIV. Then we check the virus load. It's high, it's low. So how do you manage? How do you give prophylaxis in case 1 for the baby? Here she is not on any drug. The virus load is high, so the transmission rates are high. So I have to give nevirapine with zidovudine for minimum 6 weeks, and later we will decide whether to continue or not. Case 2, she is on drugs and the load is less, so we give nevirapine for 6 weeks. This is what you have to remember. Coming back to the question, lady is on HIV positive, not on any drug, means high risk. So better to give 2 drugs for 6 weeks. So this is how we manage it. Now any HIV positive patient, the best combination will be TLD, tenofovir, lamivudine, dolutegravir. That's the best combination for newly diagnosed HIV patient. Again they will ask you post-exposure prophylaxis. Suppose you were working in the hospital, you gave injection to HIV positive and you got a prick. That is called post-exposure prophylaxis. Then also you use a drug TLD combination, but the crucial thing is how many days this has to be taken is 28 days. And as early as possible, within 72 hours it has to be started. So these are the things which are tested here. Yes sir. Now a correlation between microbiology and pharmacology. So identify the parasitic infection occurred due to consumption of raw undercooked organism shown in image. Obviously it's a crab. So what is the drug of choice for that parasitic infection? Now tell me, what is the parasitic infection you get if you eat undercooked crabs? Then we will answer. Let us see how much you have revised your micro. Yes. So undercooked crab, if you are using, so the infection is Paragonismus westermani, the lung fluke. So the drug of choice for lung fluke is praziquantel. Now coming on to the drug of choice. Now I will be telling you drug of choice, but you have to correlate with your microbiology. For all cestodes, Taenia, Solium, Sagenata, fish, Echinana, what is given is praziquantel. Neurocysticercosis and hydrate disease, what we give is albendazole. For nematode, all nematode, what we give is albendazole. For filariasis and lower, we use DEC, diethyl carbamazine. Strongyloidosis and onchocerciasis, what we use is ivermectin. Ivermectin is also used for managing a skin condition, and that is scabies. Cutaneous larva migrans, we use ivermectin. If not there, we can go for albendazole. Visceral larva migrants, we use albendazole. Flukes, for all flukes, the drug of choice is praziquantel. That's why we gave it for lung fluke Paragonismus westermani. Liver fluke, also called as Fasciola hepatica, the drug of choice is different, and that is triclabendazole. Okay, triclabendazole. So never ever miss these things. I just want to add up where metronidazole is the drug of choice. So metronidazole is a drug of choice for amoebiasis, both intestinal and extra-intestinal amoebiasis. It is a drug of choice, metronidazole. And also, what is a condition where you see clue cells, that is bacterial vaginosis? There also it is drug of choice. It is also drug of choice for Trichomonas vaginalis, where you see the strawberry cervix. And also it is a drug of choice for anaerobic infections, which is below the diaphragm, infradiaphragmatic anaerobic infection. And the one which is tested with metronidazole is the disulfiram-like reaction. Yes, can you tell me which condition nitazoxanide is the drug of choice? Which organism nitazoxanide is the drug of choice? For toxoplasmosis, let me tell you, toxoplasmosis, the drug of choice is sulfadoxine plus pyrimethamine. Yes, tell me, Nita. It is for cryptosporidium. I think you have studied that in microbiology. Yes, you know Sai Krishna, very good. Okay. Let's move on to the next question. A cancer patient was on chemo with cisplatin. After therapy, his leukocytes are depleting, leading to leukopenia. So he was given an anti-cancer drug and there is leukopenia. Which of the following will increase the WBC count? Oprelvecin is interleukin 11 analog. Remember 11 kin interleukin. It is for thrombocytopenia due to anti-cancer drug. Filgrastim, you see the name Grastim. It is a granulocyte colonostimulating factor. This is the one which is given to increase WBC count. Anything ending with poietin, darbepoetin, epoetin, it's a derivative of erythropoietin. It is given if there is anemia due to cancer drugs or anemia due to CKD. Loperamide is given for non-infective diarrhea. Non-infective diarrhea. Also, it is given for cancer-induced diarrhea. So these are the three important things they keep on asking. How do you manage the anemia, leukopenia, thrombocytopenia due to anti-cancer drugs? Can anybody tell me how do you manage cancer-induced thrombosis? How do you prevent cancer-induced thrombosis? What drug will you use? For that, the prevention is done by low molecular weight heparin, LMWH. I have discussed CANV. Then there is a problem called tumor lysis syndrome. When you kill so many cancer cells, the uric acid goes up. So the treatment for that is an enzyme called RAS buricase. If that is not available, we use a drug called allopurinol. These are for tumor lysis syndrome. Again, another complication when you treat a cancer is the calcium goes up. It is called hypercalcemia of malignancy. In toxoplasmosis, can we use albendazole? No. If calcium goes up, then we use a drug called zoledronate, which belongs to bisphosphonates. We can give them. So these are the common adverse effect of anti-cancer drugs, and how do you manage is frequently tested. Okay, yes. Now this chemoman I keep on repeating in every classes. Remember, cisplatin can cause ototoxicity and nephrotoxicity. The bleomycin and busulfan can cause pulmonary fibrosis. So anybody can tell me which antiarrhythmic can lead to lung fibrosis? Yes. And the donrobussin, trastuzumab, they can cause cardiotoxicity. Cyclophosphamide, C bar Y, it can cause hemorrhagic cystitis. Sir, can we prevent hemorrhagic cystitis? How do we prevent? We use a drug called mesna. Can we prevent cardiotoxicity by donrobussin? Yes, we use a drug called dexrazoxane. So it is an iron chelator which can prevent cardiotoxicity done by robicins. And a favorite drug which are tested again and again in anti-cancer drug is the M drugs, mitomycin. So it is written as mitomycin C, and it is used in ENT practice. Where do you use in ENT? In ENT it is used to prevent nasal stenosis and laryngotracheal stenosis. Nasal stenosis and laryngotracheal stenosis prevention. In eye, it is also used for treating In eye, it is also used to manage pterygium. Again, another drug which is frequently tested in your exam is one common drug, methotrexate. So what they will ask you is, what is the mechanism of methotrexate? Methotrexate inhibits an enzyme called dihydrofolate reductase. Now, my question to you all, what is the antidote for methotrexate toxicity? Please tell me, what is the antidote name? The antidote is folinic acid. Folinic acid. Nobody answered that? So please never forget methotrexate. Now whenever we think of methotrexate causes megaloblastic anemia and it can cause hepatotoxicity. So what monitoring will you do when you give methotrexate? You have to remember liver function test. You have to monitor for LFT. And which cancer drug can lead to flagellate dermatitis is again a frequently asked question. Flagellate dermatitis is caused by the drug called bleomycin. And again they will ask you which drug can cause hand-foot syndrome. It is your favorite 5-fluorouracil and capecitabine, commonly causing hand-foot syndrome. So these are the tested ones. You have to remember. Moving on to the next question. A 28-year-old male, each year in the spring he develops runny nose, itchy watery eyes, sneezing. So that means he has allergic rhinitis and allergic conjunctivitis. He is now treated with antihistamine for the same. He had palpitation, ECG shows QT prolongation. Which antihistamine was prescribed? Yes, this you should tell. Which antihistamine can lead to QT prolongation? Please answer this. Yes, it is the astimazole which can lead to QT prolongation. One more antihistamine is terfenadine, and they have been banned. Okay. Now fexofenadine is a derivative of terfenadine, but it will not cause QT prolongation. If you remember the antihistamine, we have two generations, the first generation and second generation antihistamine. The main problem with first generation is they cause sedation. The second generation has no sedation property. But even though theoretically we are telling no sedation, sometimes cetirizine can cause sedation even though that is second generation. Now tell me, in second generation which produces no sedation or least sedation? If they ask you, it is fexofenadine. So fexofenadine has shown to reduce or no sedation at all. Even though you people have taken cetirizine, you understand this. स्पार्टन एंड ग्रेट सर जी, हार्ट फेल्यूर अरिथमिया में बहुत सारे ड्रग्स देते हैं, किस में क्या देते हैं वो समझा नहीं आता है. डियर स्पार्टन, सी दैट हैज़ टू बी made understood when we take case scenarios. So plainly at this point of time I may not be able to tell you all those things because of time constraint, and the context should be given. आपको केस देना है, केस देने के बाद मैं समझा सकता हूँ. ऐसे ही समझाने से वो आपको मालूम नहीं पड़ेगा. सो विल टेक वन मोर क्लास रिगार्डिंग दैट. राइट नाउ एग्ज़ाम के लिए इतना काफ़ी है. ठीक है. Now the next question is, a patient presented to the emergency with blood pressure of 220 or 130. The non-contrast CT shows intracranial bleed. Which of the following drug is avoided among the following? So patient has high blood pressure and bleed, so he is having hemorrhagic stroke. He is going for hemorrhagic stroke. Okay, I will come to that, Sai Krishna. Now already there is bleeding. What you should not give? What you should not give is what? Fibrinolytics. Tenecteplase is a fibrinolytic. So if you want to use tenecteplase should be used in ischemic stroke, not in case of hemorrhagic stroke. So don't give tenecteplase. So tenecteplase is contraindicated in hemorrhagic stroke. It is contraindicated in non-ST elevation MI. So let us understand certain important other aspect. Anticoagulant. So what do they ask in anticoagulant? That we will understand. Anticoagulant, number one we have heparin. Now what is the antidote for heparin? It is protamine. Does it require lab monitoring? Yes, it requires two lab monitoring, APTT and PT. Second, we have low molecular weight heparin. Does it have an antidote? Yes, same thing. Does it require routine lab monitoring? No. Third, we have similar heparin. The name is called fondaparin X. Does it have an antidote? No. Does it require routine monitoring? No. Number 4, we have direct thrombin inhibitors, for example lepirudin, argatroban. Do they have an antidote? No. Do they require monitoring? Yes, APTT and PT. So all these 4 drugs are injectable anticoagulants. Then comes our oral drugs. So the major drug is warfarin. Does it have an antidote? Yes, vitamin K. What parameter do you monitor is INR. Nowadays we have the drugs called NOVAX. NOVAX stands for novel oral anticoagulants or directly acting oral anticoagulants. These are, the name is dabigatran. What is the antidote? Dabi, daropina. Dabi, idarucizumab. Do they require monitoring? No. Then the drugs ending with apixaban, betrixaban, they end with exaban. So these are direct 10A inhibitors. Not antidote, sir. Doxorubicin is not an antidote. Did I write like that? I told you, if doxorubicin is causing cardiotoxicity, to prevent that we use dexrazoxane. Harish Swami. Right, I was telling you apixaban, it's a direct 10A inhibitor. Does it have an antidote? Yes. The name is andexanet alpha. Remember, hexa here, hexa here. No need of routine lab monitoring. Then let me add up one more point for you. The thrombolytics. What are the thrombolytics we have? Thrombolytics are also called as fibrinolytics. We have streptokinase, urokinase, altiplase, retiplase, tenecteplase. Where are they used? They are used in ischemic stroke, ST elevation MI, pulmonary embolism and DVT. Where they are not used, thrombolytics, contraindicated in, I told you, hemorrhagic stroke and non-ST elevation MI. Now, how do you manage overdose of thrombolytics? We use the opposite, that is antithrombolytics. What are these antithrombolytics? The name is tranexamic acid and ECA, epsilon aminocaparic acid. These are the antidote for thrombolytic or fibrinolytic overdose. Right, so I hope with that we are done for today's discussion. Any doubt from your side? I am open to take up that. This is the Telegram group and the Instagram where you can follow me for any updates. So my best wishes for your upcoming FMG exams. I tried to cover most of the important points in this 3-hour session. So any other doubt, I am ready to take up here. Okay, so I think most of the things we have covered here. So we covered CVS, CNS, RS, GIT, endocrine, remember mainly diabetes and thyroid. And then we covered antimicrobial, anti-cancer, general pharma, and asthma. Autocoids, mainly gout, they will ask you. So most of the time, important aspect we already covered here. Okay, so exams are nearing. Not only nearing, it's very, very nearby. Okay, so please understand you have really prepared well, and at this point of time it's the question of confidence. You should have more confidence, belief on yourselves. Don't listen to any other fellow mates, because their reading capacity, studying capacity is different compared to yours. Not everybody are same. Some people can study in a single day, some take 2 days, some day take 3 days. The speeds are different, so don't compare others with yourselves. And I wish all of you the best of luck for your upcoming FMG exam. So I pray the God to give you easy questions, scoreable questions, and not only that, come up with flying colors. I think PDF will be there in Medhub Telegram group. They are posted. They are being posted. They are posting in the comment section. You can join the Telegram group. There you can find the PDF, because here PDF you can't share in the comment section. That's the problem. Okay, NEET PG will plan as early as possible. So this is mainly for FMG. Okay. So if there are no doubts, that means we'll wind up today's session. Thank you all. Thanks for your cooperation.